Let's do a deep dive into the phenomenon, the auscultatory gap. By definition, it is a temporary disappearance of cough sounds during cough deflation, followed by their reappearance at a lower pressure. If you fall into this trap, the consequences are dual and disastrous. You will drastically underestimate the true systolic BP, and you can overestimate the diastolic BP. So who is at risk? We see this predominantly in elderly hypertensive patients, individuals with advanced carotid atherosclerosis, and anyone with severely increased arterial stiffness. So the question is, how do we defeat this hidden clinical trap? The absolute gold standard is the palpatory auscultatory method. This means you must estimate the systolic pressure by touch before you even put a stethoscope to the patient's arm. If you skip the palpation step, you are flying blind. So let's look at exactly how to perform this dual-step approach properly. Step 1. Estimate systolic pressure by touch. Wrap the cuff properly around the bare upper arm. Locate the radial pulse at the wrist and keep your fingers firmly on it. Now, inflate the cuff steadily. Note the exact pressure on the manometer where the radial pulse completely vanishes under your fingers. Once you find that point, deflate the cuff completely and let the patient's arm rest for 30 to 60 seconds. You now have your true tactile baseline. Step 2. Listen with your stethoscope. Place the diaphragm or bell over the brachial artery at the antecubital fossa. Now, inflate the cuff to 20 to 30 mm mercury above the pressure where the radial pulse disappeared during step 1. By doing this, you guarantee that you inflate the cuff higher than any potential hidden auscultatory gap. Now deflate the cuff slowly at 2 to 3 mm mercury per second and listen intently for the true phase 1 and phase 5 points. Let's look at a concrete, real-world example of how dangerous skipping this can be. Imagine a patient with true blood pressure of 200 over 90 mm mercury who has a massive auscultatory gap sitting right between 170 mm mercury and 140 mm mercury. If you skip palpation, you might blindly inflate the cuff to 160 mm mercury, thinking that's high enough. When you open the valve, you hear absolutely nothing at first because you are sitting right in the middle of the silent gap. The sounds finally appear at 140 mm mercury. And you record the blood pressure as 140 over 90 mm mercury. So what is the terrifying result? You just missed a dangerously high stage 3 hypertensive crisis of 200 mm mercury by a massive 60 mm mercury margin. Now, let's look at the right way. You use the palpation step first. So as you inflate, you feel the radial pulse vanish at exactly 200 mm mercury. So yes, you know their systolic pressure is up there. Now you safely and intentionally inflate the cuff all the way to 220 or 230 mm mercury. As you deflate, your stethoscope catches the true first phase 1 sound at 200 mm mercury. Then you watch the dial as the sounds go completely silent at 170 mm mercury and reappear out of nowhere at 140 mm mercury, and then finally vanish for good at 90 mm mercury. So what is the result? You get a perfectly accurate reading of 200 over 90 mm mercury and you successfully document a 30 mm mercury auscultatory gap. So you saved the patient and you aced your clinical exam. The absolute key takeaway here is that if you ever hear Korotkov sounds instantly vanish and then return a few moments later as you deflate the cuff, you have crossed an auscultatory gap. Do not ignore it and do not think your stethoscope slipped. Always explicitly document both the true blood pressure numbers and the exact presence and span of the gap in the patient's medical chart.